shake it off, I shake it off. I never miss a beat. I'm lightning on my feet, and that's what they don't see. That's what they don't see. I'm dancing on my own, dancing on my own. Make the moves about to go.
Welcome. On behalf of the American Heart Association, the Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership to the 5th session of the 2020 Hypertension Control Summit Series. We are thrilled with the engagement and attendance at the first couple of sessions, and it is so exciting to see the momentum of this statewide effort continue to grow. For those of you joining for the first time, my name is Dr. Takia Wilson, and I am just really thrilled to be here with all of you today. It is my pleasure to guide you through an exciting agenda for the Hypertension Control virtual poster session. I want to thank you for being here today and for contributing your efforts towards the same goal, which has motivated and encouraged all engage so many health leaders across Texas. We are marching towards hypertension control across the state, and each of you plays a vital role in making that happen in our goal of reaching 70% greater, one patient at a time. Now, before we begin, I have a few notes and housekeeping items to share before we dive in. For those of you who would like to go back and listen to the previous sessions, they are posted to this event series website, and the links are now in the chat. For today's summit, everyone except the speakers will be muted to manage background noise. During the presentations, you will see the speaker and the slides side by side using the speaker view as opposed to gallery view. Dragging the boundary line between the two windows will allow you to enlarge the speaker or the slides to your preference. You can find additional guidance in the chat right now. We welcome you to engage via the chat function throughout the event. To start, please introduce yourself here in the chat with your name and organization. Thank you so much for those responses and getting connected with your peers. And new this session, we will have a fan favorite voting component, which keeps us all actively engaged in our presentations. Today, our agenda begins with the highly anticipated virtual hypertension poster series. There are 9 dynamic presentations for you today, and we have broken them out for topics based on 3 categories: data-driven hypertension initiatives, community-based hypertension control, and leveraging technology and clinical engagement. So just how will this virtual poster session work? Well, we will have 3 different speakers present their findings in each category in a rapid-fire format. After the speakers present, we will drop a link in the chat to the digital poster for you to review online. We invite you to share comments or ask questions for the speakers using the chat function. Our team and co-authors will also be responding to questions real time in the chat, and we will address as many questions as possible during the brief Q&A at the end of each category. At the end of each category, we will launch a poll for the audience to vote on your favorite abstract, which best highlights hypertension initiatives across our state of Texas. The presenter's name will appear on the screen for 15 seconds. And after that, you select your choice of who you think presented the best hypertension information today. But the winners will not be revealed today. You will have to tune back in next month when the winners will be announced at our awards session on December 3rd. Now let's get started with our first category. It is my pleasure to introduce our first speakers. Dr. Maria Cooper is the Manager for Chronic Disease Epidemiology at the Texas Department of State Health Services. Dr. Cooper completed her PhD in epidemiology at the University of Texas Health Science Center School of Public Health. The title of Dr. Cooper's presentation is Racial and Ethnic Disparities in Hypertension Prevalence Among Texas Stroke and Heart Attack Cases, Findings from 2 Hospital Registries. Joshua Singleton is a senior attending Prairie View A&M University, majoring in biomedical chemistry. He is a part of the Undergraduate Medical Academy at Prairie View A&M University, which focuses on producing excellent future medical providers. The title of Joshua's presentation is Developing a Data Map to Implement Community-Based Intervention for the AHA's Check Change Control Blood Pressure Cuff Loaner Program in Dallas. Megan Coulter is the Maternal Health and Safety Coordinator for the Texas AIM Hospital data. Megan has been a part of the team since 2018 and serves as the Texas AIM Hospital Data Lead. The title of Megan's presentation is From Recommendations to Action to Improve Maternal Health and Texas AIM. We are so excited to hear these presentations. Dr. Cooper, if you can unmute your line, the virtual stage is now yours.
Thank you. Good morning. I'm Maria Cooper. I'm from the Texas Department of State Health Services. And so today I'll be presenting on racial and ethnic disparities in hypertension prevalence among Texas stroke and heart attack cases. And so this is my poster, which is linked to on the AHA website for reference. You can see here I have figures as well as summaries of findings, but I'll go through these in more detail in the next few slides. Next slide, please. So as a background and introduction, it's fairly well documented that in the United States, non-Hispanic Blacks are significantly more likely to have hypertension than other race ethnicity groups. However, this disparity is less well documented among patients who've been hospitalized for stroke and heart attack. So that was the purpose behind this presentation, was to examine the prevalence of hypertension among stroke and heart attack patients by race ethnicity group. We look at the prevalence over a 10-year trend, so from 2008 to 2018, and this analysis was conducted among Texas hospitals. Next slide, please. So these data are from 2 hospital registry systems in Texas, one for stroke, which is called Get With the Guidelines Stroke, and one for heart attack, which is called Chest Pain MI Registry. So the Texas hospitals agreed to share their data with the Texas Department of State Health Services. This was part of a legislatively funded data collection initiative. The number of hospitals varied each year. So for stroke, it was between 21 to 50 hospitals, and for heart attack, it was between 12 and 46. The prevalence of hypertension was calculated for cases who had hypertension listed as a documented pre-existing condition in their medical record. And we looked at hypertension by 4 race ethnicity groups, so non-Hispanic Blacks, non-Hispanic Whites, Hispanic, and non-Hispanic other. So the number of cases included in each analysis is listed here. For stroke, it was about 115,000, and for heart attack, it was nearly 65,000. And I should also mention that for the heart attack registry patients, data from 2008 was excluded due to a small sample size of participating hospitals. Next slide, please. So really the main takeaways from this presentation, the results and conclusions are listed here. We can see from the findings, and you'll note in figures 1 and 2, that hypertension was an extremely prevalent pre-existing condition among both stroke and heart attack patients. So for stroke overall, 82% of patients had hypertension listed as a pre-existing condition. And for heart attack patients, 78% had hypertension listed as a pre-existing condition. We can see in the time period examined that the prevalence overall was relatively stable. However, there were small, slight increases and decreases noted. In particular, for stroke cases over the study period, there was a slight decrease, and for heart attack cases over the study period, there was a slight increase overall among all groups. However, for both conditions, for both stroke and heart attack, non-Hispanic Black patients had the highest prevalence of hypertension compared to the other three race ethnicity groups. So these findings show persistent health disparities over this 10-year time trend period, especially for the non-Hispanic Black group of patients. This highlights the need for continued evidence-based prevention for this population, as well as management of hypertension for this population in Texas. And this concludes my brief summary presentation, and I'm happy to take questions during the Q&A period.
Hello. Hello, everyone. My name is Joshua Singleton, and I'll be presenting on developing a data map to implement a community-based intervention for AHA's blood pressure cuff loaner program in Dallas, Texas. Next slide, please. For the introduction, as we know, hypertension is one of the leading causes of death in America, especially among African Americans. To control these negative effects, patients must take proper lifestyle changes and be self-aware of their blood pressure. With that being said, the American Heart Association has implemented the Check, Change, Control program, which is an evidence-based hypertension management program that utilizes blood pressure self-monitoring to help patients be more self-aware of their cardiovascular health. Now, the Check, Change, Control program acts as a database, and it allows participants to use this database to track and keep up with their blood pressure whenever they log it. So in this study, the CCC data for the participants in Dallas, Texas was analyzed. Next slide, please. So the methods of analysis, the primary method of analysis was Excel. And we used Excel to organize the data into different graphs and a nice geomap. The data consisted of 2,387 enrollees, and the time period analysis was from 2017 to 2020. The participants were about 50-50, 54% male and 46% female. And for the main method of analysis in regarding blood pressure, we put the participants into three categories that were based upon hypertension, normal blood pressure, and elevated blood pressure. You can see the requirements there in the thing. The data set was also analyzed by their age, where they were in location, zip code, ethnicity, and the number of blood pressure readings that they logged in the system of the CCC database. And like I said before, you can see the requirements for the blood pressure monitoring team on the website that they have posted. The next slide, please. So the results, I'll go back to the graph at the end. The results showed that from the data map, it demonstrated a further need for hypertension management in areas with higher prevalence of disproportionate differences between African Americans in Dallas, Texas. And these zip codes were 75287, 75238, and 75288. So in conclusion, these zip codes need a further look, would be great for having a hypertension blood pressure loaner program in those areas. So the next step would be to go in those areas and find places where it would be effective to put those blood pressure loaner programs so people can, take advantage of it. And also evaluate insurance coverage so all that can be in order. Could we go back to the first slide with the graph, please? So with Excel, it used us to find a nice geomap with all the participants' data in there based on their zip code. And this is a map based on their hypertension readings. So at the top top, we have 75287, which was a pretty high reading. As you can see with the legend, the darker in red, the more hypertension people in the area, participants in the data in the area. So we got two clusters, one at the top, and that one big cluster at the bottom with 75238 and 75288. So with that data, we can effectively go and put those blood pressure lowering programs in those specific places to further assess the need in Dallas, Texas. And that will be all. Thank you so much.
Hello, my name is Megan Coulter, and I'm the Maternal Health and Safety Coordinator and Texas AIM Hospital Data Lead at the Texas Department of State Health Services. I'll be presenting today on behalf of the DSHS Texas AIM team. I would first like to recognize my team and the additional authors you'll see listed here. Julie Stagg, Healthy Texas Mothers and Babies Branch Manager and Texas AIM Program Director. Ashley Steenberger, Maternal Health and Safety Coordinator and Texas AIM Operations Lead. Laura Wando, Maternal Health and Safety Coordinator, and Maternal Health and Safety Nurse Consultant, Rosa Maria Diadonato. We can't talk about our work without recognizing the Texas AIM Obstetric Hemorrhage faculty members and our faculty chair, Dr. Carrie Epps. Other partners include THA, UT Tyler, Mama's Voices, and Black Mamas Community Collective, hospitals engaged in Texas AIM, of course, and many more. As you'll see, we'll be presenting on moving recommendations to action to improve maternal health and safety with Texas AIM. Next slide. DSHS supports administration of the Texas Maternal Mortality and Morbidity Review Committee. DSHS and the Review Committee publish joint reports biannually to share findings and recommendations for prevention of future maternal mortality. The most recent report will be released by or before December 1st of this year. Findings have informed the committee's development of recommendations to remove the incidence of pregnancy-related deaths and severe maternal morbidity in Texas. Findings related to hypertension from the 2018 report include hypertension, preeclampsia, along with hemorrhage and cardiac events are leading cause of pregnancy-related deaths in Texas. Hypertension is often a contributing factor in maternal mortality, even in cases where another cause precipitated death. Marked disparities exist, with Black women bearing the greatest burden of hypertensive morbidity and mortality in Texas. Along with other contributing factors, failure to recognize maternal early warning signs and high-risk maternal health status, as well as delays in treatment and inadequate or ineffective treatment of hypertension, hemorrhage, and infection, are identified as leading factors contributing to pregnancy-related deaths. DSHS works to translate the review committee's recommendations into action through population-based programming. Next slide. This leads us to our program, Texas AIM. Over the past 2 years, DSHS and its partners have been working with birthing hospitals in Texas to implement the AIM Obstetric Hemorrhage Patient Safety Bundle. There are 219 hospitals, which is 98% of birthing hospitals in Texas, who have voluntarily enrolled in Texas AIM. Texas AIM hospitals serve greater than 378,000 women each year, which covers over 99% of Texas births, and that's 10% of the nation's births. Hospitals are currently at varying levels of bundle implementation, and we are so proud of the hospitals and the work that they've done. Next month, we'll be holding a virtual meeting with our hospitals to celebrate the work that they've done, as well as kick off the next bundle, severe hypertension and pregnancy. Next slide. If you're curious about the bundle and want to know more, you can see the screenshot here, and you can also visit the website listed here as well. Next slide. So how will DSHS and its partners be working with hospitals to implement the hypertension bundle? Well, we'll be using the same infrastructure that we built for the obstetric hemorrhage bundle. Texas AIM uses the Institute for Healthcare Improvement's Breakthrough Series collaborative model for breakthrough improvement as a foundation for the program. IHI Breakthrough Series is a vehicle for identifying, testing, and spreading changes that are effective for improving care and outcomes for defined populations. As you'll see here in our model, there are various components, including a pre-work period, then learning sessions, and action periods. During learning sessions, hospital teams and faculty work together to integrate learning on bundled topics and plan for how to immediately incorporate what was learned, including specific changes into their improvement processes. Action periods took place following each learning session. Monthly calls were held with PLES teams and included content-driven topics and tailored discussions to coach teams in overcoming obstacles and accelerating improvement efforts. Next slide. We can start to see some impressive initial data from hospitals, such as showing an improvement from baseline in quantitative blood loss measurement through recovery, implementing policies and procedures, performing formal debriefs after cases with major complications, and more. We have a legislative report coming out on December 1st with our findings, and we would be happy to share that with anyone interested. The hypertension bundle is clearly going to include different challenges and opportunities. Unlike hemorrhage, severe hypertension goes outside of the walls of the hospital and into the communities. We'll be working with our hospitals and encouraging them to work with their community partners as well as engage in shared learning, so hospitals are able to learn from each other and share how they work with community partners and stakeholders. We're already excited for next year's Texas Hypertension Control Summit and to be able to share with you what we've learned. We know from hearing from hospitals through surveys, evaluations, and just word of mouth that they're excited for this work. We all know it is going to be hard and involve a lot of work, but it's worth the work. Thank you for your time, and if you have questions, you can visit the Texas AIM website listed here or email us. And I will now hand it back over to our moderator. Thank you.
Excellent presentations. Oh my gosh, thank you all so much, Dr. Cooper, Megan, Joshua, for just sharing your expertise and data as it relates to our hypertension efforts in the state of Texas. And now, as promised, we have a poll for you to vote for your fan favorite of the abstracts that were presented today. So the poll will be up for 15 seconds. So there it is right there with the title and the co-authors listed for you to select your favorite category. We'll leave it up for 15 seconds, and I'm looking at the chat. I don't see any questions right now. Looks like there's a lot of activity with the links being placed and other questions being fielded by co-authors and the audience. So thank you so much for that. Okay, I think we're ready to close the poll and we can move on to our second category of community-based hypertension control. I'm so delighted to introduce our second presenters today. Kennedy Steele is a senior majoring in biology at Prairie View A&M University. She serves as the president of the Texas Undergraduate Medical Academy and plans to attend medical school and continue research. The title of Kennedy's presentation is Community Intervention to Promote Self-Monitoring Blood Pressure. Kim Bush is the program director for the Center of Population Health, Analytics, and Quality Advancement in the Texas Area Health Education East Northeast region within the School of Community and Rural Health at the University of Texas Health Science Center at Tyler. Kim has over 24 years of experience in behavioral and community health working with diverse populations. The title of Kim's presentation is Community Health Workers, a Secret Weapon to Controlling Hypertension. Maya Adams is currently a second-year MD MPH student at UT Southwestern Medical School. Maya attended Johns Hopkins University for her undergraduate degree in neuroscience. Maya hopes to practice community medicine and address racial disparities in healthcare after graduating. The title of Maya's presentation is Implementing Community-Based Blood Pressure Cuff Loaner Program for participants in the AHA Check Change Control Program. Kennedy, if you can unmute yourself, the virtual stage is yours.
Thank you, Dr. Wilson, for that introduction. As she said, that I will be talking about community intervention to promote self-monitoring blood pressure. So like she said, my name is Kennedy Steele, and I had the opportunity to work with Dr. Gimple as well as Josh on this project. With over 100 million Americans having hypertension, the racial disparity in hypertension has been recognized for decades, with African Americans having greater risk than Caucasians. Less than 20% of African Americans who have high blood pressure are adequately treated. Studies have shown that community involvement is instrumental in spreading awareness and education on how to independently monitor blood pressure. The Check Change Control program implemented by the American Heart Association is an innovative evidence-based program that has increased patient follow-up through self-monitoring and community interventions, as well as instructions on how to take their blood pressure in order to independently monitor their health during times, especially during times like this with COVID-19, when healthcare facilities are not easily accessible. Next slide. So the objective of this literature review was to compare studies that demonstrated the community interventions that can support the CCC program. Specifically, we looked at the Dallas County area. Next slide. Oh, thank you. So for our methods, we searched up databases. We utilized PubMed, Google Scholar, Access Science. Some of the keywords we used were blood pressure, community interventions, check change control. I wanted to specifically go into something that was more long-term. I know there's sometimes when there's programs, we can't keep them for that long. So then I went in to look at an article that talked about community-based hypertension control programs that work. And that was actually written by Wayne Kong. The literature focused on bringing education and awareness of hypertension where target communities congregate, such as churches and barbershops. Then we looked specifically in the Dallas area to see which communities where hypertension is very prevalent. And then we did descriptive analysis that Josh talked about actually earlier. Okay, next slide. So from my literature review from Dr. Wayne, it was concluded that studies have shown programs with community partnerships that have led a substantial decrease in morbidity as well as mortality from hypertension. And the study saw improvements with African Americans continuing their treatment, as well with patient compliance increasing nearly 60%. Also from what Josh presented, we looked at that data as well. So it was apparent that African Americans and Hispanic participants were disproportionately affected by hypertension in the data set. So more than 83% of African American participants and 64% of Latino participants reported blood pressure readings that were classified as hypertensive, compared to only 37% of white participants that had hypertension. Also, the studies had shown programs with community partnerships that did lead to a decrease in morbidity and mortality, like I said, and that was by Dr. Kong. Therefore, we hypothesized that community intervention in studies will increase blood pressure monitoring, especially in the Dallas County area. We strategized ways to use different partnerships to promote health literacy, hypertension awareness, self-management. Like I said before, we did look into specifically the churches, barbershops, and then we also explored the school districts in the Dallas County area. So in Dallas County specifically, we looked into that area to see that, and we noticed that there was a lack of understanding of how to obtain and use health coverage, navigate the health system, and adhere to treatment plans and provider instructions. Therefore, as a result, we strategized ways to use different partnerships to promote health literacy and hypertension awareness and self-management. So we proposed the initiatives, which included collaborating with churches in the Dallas area, more specifically the mega churches. We saw that they had a great they complied and that they were very involved in the community. We knew that it would be easy for ones to want to volunteer and help with the self-monitoring blood pressure, which is why we focused on the church. We also know that attendance, that's every Sunday, so you're seeing those people on a weekly basis. We also looked more for the African-American men at barbershops where African-American males go at least 10 times a year. We thought this would be a great opportunity to refer clients to doctors and to spread hypertensive awareness. We also thought about after school clubs for just learning like more preventive measures for the students and being able to come home and help their grandparents or parents as well to get them engaged. Next slide. Next slide again, I'm sorry. Okay, so for the conclusion, we have our next steps. So some of the organizations identify where the CCC program can be expanded in the Dallas area. We looked at Inspiring Body of Christ Church, the Potter House, Friendship West, Anatok, Concord, Dallas ISD, which is the school district, A Cut Above Barber and Beauty Shop, and Plugged In Executive Salon. We hope to see this study be implemented into the Dallas County area. I would also like to thank the American Heart Association, Dr. Gimple, and the Undergraduate Medical Academy for their support and guidance. And thank you guys for listening.
Hi, thank you, Kim Bush, and I want to thank you for allowing me to present today on behalf of our region here in Northeast Texas. If you would look at the poster, you can see that many studies show that the region does suffer from a higher prevalence of high blood pressure, and it was identified as a health priority. Next slide, please. To address the need, DSHS contracted with UT Health Science Center to improve hypertension by implementing a program focused on self-monitoring and management. So leaders from the Northeast Center for Rural Community Health, the center, which that's what I work in now, however, it's been renamed. So, but at the time it was called the Northeast Texas for Rural Community Health, and UT Health Science Center Clinical Operations collaborated to create a comprehensive program for patients with hypertension. In addition, the program has been offered throughout the region for all community members, so it's not just within our clinics or our hospital setting. Referrals to the program, we receive them from providers. We do have a bi-directional program through our electronic medical record, but also community health workers, community agencies, organizations, individuals can request to be included in the program. We go when outreaches were allowed. We don't get to do those now, except through virtual opportunities. We were, meeting people out there in different areas and inviting them to our program, sharing about our program. We still do that. We're just having to find different ways to do that. But our goal is to share resources, as it is a free program open to all community members within the Northeast region. We also have many participants that join and they invite their family or friends. We had one cohort, we had a wife, she came, her husband brought her every time to the cohort meetings, but he did not want to join even though he had high blood pressure. So at the next cohort, he did join and she actually came with him to support him, which was really nice to see that family support. Once referrals are received, the CHW does contact the individual and completes a lifestyle assessment form. It's just a short questionnaire that we created that the CHW uses to begin building that relationship with the participant. It's not that we're just asking them questions left and right. We do it in a conversational interviewing type to get to know them more and start sharing dates about upcoming workshops and what are their goals? What are their actual needs? Or, do they work? Are they able to come? And of course, now with COVID, things are a little bit different, but we still have the opportunity to provide this to our participants and community members. So workshops are held in 4 or 5 various places, such as clinics. We've had them at libraries, other agencies or organizations. We do them at different times of the day, and we even do them in the evening. We now have a virtual workshop. When COVID first came out, we did have to change everything to virtual. And so once we finished that this summer, we started doing a kind of a hybrid opportunity. So we do have face-to-face workshops. However, we do practice all of the guidelines and rules to keep everyone safe, temperature screening, mask, sanitizer, social distancing. And then we also, if someone is wanting to join through Microsoft Teams or on which you can do through application, or you can call in and we can do it that way. So we just have to be flexible to meet our patients and our participants where they are. We do and have done home visits in the past. We're not really doing home visits right now unless it's absolutely necessary. We keep the patient or the participants at a common location. We can go to their home. We normally don't go in. So we're just having to practice being very cautious and practice all measures to keep everyone safe. So our program actually, it is 12 weeks, but it really lasts a total of 14 weeks because of the orientation session. We have 5 additional workshops and a graduation. During the orientation, participants will read and sign an informed consent, and they also receive a blood pressure monitor. CHWs teach the class. They teach the cohort participants how to measure their blood pressure accurately through the guidance of American Heart Association. We give them a blood pressure passport, which we obtain through DSHS, and we show the participant how to record their readings once in the morning and once in the evening. And they bring those back to the workshop or send them in electronically to us if they're doing this via phone or on Teams. And we capture that every couple of weeks is when we have our workshops. We do put a de-identified sheet and share that at the end of each cohort with DSHS. So during the workshop, participants do receive heart health and cholesterol management education. They also get additional tools to increase their levels of health literacy regarding these topics. We provide them different information, different sets of information through various resources such as American Heart Association, the National Heart and Lung Blood Institute, Department of State Health Services, American Medical Association. We also assist them in decreasing barriers to healthcare access, community resources, and other ways that we could help them reduce health disparities. So the workshops are structured to last about an hour, including sharing all the information, asking questions, collecting blood pressure readings. Sometimes we go over a little bit depending on the number of people, but usually it's right about an hour there. If someone misses a workshop, the CHW checks on them, via phone, email, or mail. The participants do receive a $5 gas card if they attend in person and they provide their blood pressure readings from the previous 2 weeks. And at the last workshop of graduation, we do have a ceremony, and we may have it now virtually, or we could have it in person, or both at the same time. And I only have about a minute left, so I want to share a couple other programs we have with hypertension. We do have a hypertension tracking for our patients that we have. It's a one check-in and lending library, which is a blood pressure loaner program. We have in 5 primary care clinics, 2 community locations, and mobile health integration. So as you can see on our poster, we do have several lessons that we've learned, to be adaptable, that we need support from our leadership, which is critical. And follow-up is essential to participant success. So we do have a follow-up program, a 3-6 follow-up. We will be implementing an additional 9-month and a year follow-up starting next year. We've grown since 2017. We've hired an additional CHW, a program coordinator, and we are working on implementing 7 additional clinics throughout Northeast Texas region this year. And then the next 2 years, we'll be adding additional 14 clinics. So thank you for allowing me to share with you today.
Good afternoon, everyone. My name is Maya Adams, and today I'll be presenting on implementing a community-based blood pressure cuff loaner program for participants in the AHA Check Change Control Program. I would first like to acknowledge the Department of Family and Community Medicine at UT Southwestern and Dr. Gimple for supporting us in this project. Next slide. The American Heart Association implemented the Check Change Control Program with a goal of decreasing mortality from cardiovascular disease through helping community members track their blood pressure and achieve better control. Traditionally, hypertension is managed in a primary care office setting. However, self-monitoring blood pressure is increasing in popularity. It has many benefits, such as tracking and predicting end organ damage more accurately than traditional management, and it allows physicians to titrate medications based on patients' home readings. Importantly, utilizing self-monitoring blood pressure has had consistent and significant reductions in patients' blood pressures when combined with counseling from a healthcare provider. Next slide. The objective of our research project is to examine community-based initiatives that have implemented self-monitoring blood pressure and to propose an intervention to improve hypertension self-management for participants in the Check Change Control Program. A literature review was conducted using the following databases. We used about 15 articles to guide our implementation strategy. Next slide. In our research, we found that there's a gap in resources that a blood pressure cuff loaner program could fill, especially in underserved communities. The majority of surveyed healthcare providers utilize self-monitoring blood pressure in their practices, which is good news. However, about 13% reported having a loaner program available for their patients. Additionally, patients from under-resourced communities have a positive attitude towards self-monitoring blood pressure, but they have a few concerns, which include the cost of purchasing a monitor, as well as receiving proper training on how to use it. There's also varying insurance coverage of blood pressure cuffs, with Medicare not requiring coverage and Medicaid not providing reimbursements in a consistent way. So patients being able to obtain a blood pressure cuff through their insurance is not always an option. Additionally, self-monitoring blood pressure has been shown to reduce healthcare spending by up to $166 per patient per year. And this is through preventing comorbid conditions commonly associated with poorly controlled hypertension. Next slide. Data from the Check Change Control Program in Dallas shows that African Americans have the highest prevalence of hypertension in this city. Therefore, we wanted to focus on implementing loaner programs in areas where they live to increase accessibility. Like Kennedy mentioned in her presentation, African American churches have a rich history of participating in community-based programs, so we wanted to start there. Each community location would receive ideally a pool of validated blood pressure cuffs from varying sizes, and the average cost would be around $65. Next slide. A component of this program would be providing culturally appropriate materials to educate patients on hypertension control through lifestyle modifications that can include things like dieting, incorporating more physical activity, and how to manage everyday life stressors. Additionally, we would want to provide infographics and a checklist on proper positioning while taking their readings and common mistakes that can render inaccurate readings. Lastly, at each location, we ideally would want to have a designated staff member there to demonstrate how to use the device in person and coach the patient on what to do if the monitor shows an abnormal reading. We really believe that this community-based strategy could empower African American patients with hypertension in taking a more active role in their care while improving rates of blood pressure control. Future directions for this project include exploring possible partnerships in Dallas with churches, public libraries, community centers, and to promote the check change control program at these places and implement a blood pressure cuff loaner program. Thank you so much. Next slide.
Much to our amazing speakers in the community-based hypertension initiatives category. Kim, Maya, and Kennedy, we've all learned so much in this short time that you presented your data. So up for you now is our category 2 audience favorite poll. Please select your favorite abstract as it relates to community-based hypertension control. You can see the titles are listed again for you, as well as the authors and co-authors for each abstract. And this will be up for about 15 seconds, so don't wait. Time is ticking. I'm going to just check the chat box. Great activity in the chat box, everyone. You can see the links to the actual posters for each one of our presenters there. Thank you so much. Okay, we're going to leave it a few more seconds. We'll move on to our final category of today. And I am so delighted to introduce our final presenters in our third category for leveraging technology and clinical engagement. So Dr. Stacy Agbaid is a board-certified clinical health psychologist, a board-certified specialist in obesity and weight management in primary care, as well as an associate professor and director of behavioral health education with the family medicine residency at UT Health San Antonio, where she trains family medicine residents. The title of Dr. Agbaid's presentation is A Mindful Heart, Take 2, a self-paced online module on stress management for patients with hypertension. Natalia Williams is a health educator at UT Physicians Community-Based Clinic in North Houston. Her primary responsibilities include the development and facilitation of wellness programming for the clinic, as well as the management of programs that work to address social determinants of health, such as food insecurity. The title of Natalia's presentation is Core Connections Network for Individuals with Chronic Disease. And our last presenter for today is Annie Matthew-Cuddy, currently serving as North Texas Veterans Affairs Healthcare System Home Telehealth Nurse Care Coordinator since 2013. Annie leads to find new innovative strategies to improve clinical quality for optimizing population health with chronic disease conditions. The title of Annie's presentation is Virtual Hypertension Symposium for Veterans and Their Caregivers. Dr. Agbaid, if you can unmute your line, the virtual stage is yours.
Wonderful. Thank you so much. I'm incredibly happy to be here this afternoon.
Thank you.
Okay. There's an echo, so I just want to make sure. There we go. Okay. So I'm super excited to talk to you all about this topic of stress management for patients with hypertension. And this project initially came about because a few years ago, we had developed a group-based protocol for addressing stress and stress-related issues with patients with hypertension in primary care. And as you see on the poster, the pandemic happened and is happening, and healthcare delivery had to quickly shift. And so if we weren't doing telehealth before, we were thrown into that now. And so now some folks are feeling as experts, which is great in terms of delivering, whether it's video visits with patients or telephonic visits with patients. And so This project is a combined effort with the Dialysis Patient Citizens Education Center, which has their primary focus of doing patient education with patients with chronic kidney disease and all various aspects that affect kidney disease, which of course hypertension does that. And so the goal of this project, at least for today, is to really talk with you all about the next steps for planning a self-paced online module for those individuals who have hypertension. Next slide, please. So the presenters today have done a fantastic job talking about the rates of hypertension, the rates of hypertension in various racial and ethnic groups. And so I won't go over that again, but I will talk about psychosocial stress being a contributing factor of the development and maintenance of hypertension. I'm a clinical health psychologist, and so I'm incredibly interested in the behavioral components of disease management, specifically chronic disease management. And so Mindful Heart is the name of the stress management program that initially I had developed to really help patients deal with the psychosocial stress elements that impact their hypertension. This group was initially developed to be done in person in the primary care setting. There are lots of different group-based protocols for patients who are part of a cardiac rehab program, but there was nothing specific to primary care that could meet the needs of being brief, more of a population focus in terms of access to more than just one patient at a time, specific to primary care. So that was what this initially was set out to address. Next slide, please. And so, because of the changes that have come, I've already been doing some work with the Dialysis Kidney Citizens Education Group already. And so because of that, we decided, well, let's work together to put a self-paced online module together to really help decrease barriers to care. We don't have our patients coming in as much into primary care right now. And especially with now this second wave of the pandemic that we're in the middle of, we might have been bringing patients back into clinic, but I've met with and heard from a lot of health systems that are now switching back to mainly virtual based visits for the foreseeable future. And so with patients, especially patients who might be in rural areas or in various socioeconomic levels, that having access to broadband connections, even to do telehealth visits, might be quite difficult. And so this really opens up options to patients who may not have access to broadband connection. There are a lot of individuals in the US who have smartphone access. About 71% of individuals who are in the income bracket of 30,000 or less have access to a smartphone. And about 56% of that population also has broadband at home. And so that's a good chunk of patients who potentially could have access to this online module. Next slide, please. And I think if you hit the enter button one more time, awesome, thank you so much. So the next steps of this program is getting into the planning stages with the Patient Citizens Education Center. In early 2021, we should be putting the finishing touches on the self-paced module. And so we plan to collect data on this. And so if you are interested, if you think your site, your patient population, the nice thing about this is that it can definitely reach out to individuals in the community that may not be connected to primary care specifically. If you hover your phone over that Scan Me QR code on the screen, it'll An email should pop up where you can contact me directly if you have questions, would like to be a possible a site to have your population get access to the self-paced modules, or if you want access to this article that talks about the stress management program in more detail. If you're curious, well, what happens in each module? How long is it? Happy to discuss with you further. Thank you so much.
Good afternoon, and thank you for letting me share with you today. My name is Natalia Williams, and I'm from UT Physicians. Today, I'll be sharing our steps to transition a self-management program to the virtual platform in the wake of COVID-19. Next slide, please. So UT Physicians began implementation of the self-management program for our patient population. It's called Core Connections Network. It was developed by the Houston Food Bank. We began implementation in 2019 in person, of course. The chronic condition self-management program is an 8-week program, 6 sessions. Each session is about 2 hours long. They cover topics about self-management, nutrition, staying active, coping or stress management, and most importantly, I think, is action plan creation and goal setting. It is a curriculum that is designed to be very interactive. The participants really lead the class. There are interactive games, and it kind of serves as sort of a support group function as well. Participants are also enrolled in the Food RX program that is hosted by the Houston Food Bank, where they receive up to 30 pounds of fresh fruits and veggies and other healthy food items for the duration of the cohort, which is usually they can pick up food about 4 times from different distributions throughout the city. This serves as sort of like a reinforcement of some of the things we learn in the nutrition portions of the classes. The food bank evaluates the program through biometric data, specifically blood pressure and waist circumference. These are measured at the first session and the last session of class. They also measure patient readiness and confidence to change health behaviors through pre and post surveys. We switched off our in-person classes in about March of this year. We began doing virtual classes in May, and we began our first Core Connections virtual cohort in August. Next slide, please. So we had several challenges or obstacles or things to really think out and think through before moving virtually with Core Connections. One of them is actually adapting the curriculum to a virtual platform. Like I said, the sessions are designed to be 2 hours long, which, as we all know, living in this virtual world, 2 hours to be in front of a phone or a computer can be very long. We condensed these sessions to 1 hour. The curriculum is so well written that each session has very clear objectives in the beginning. So we've decided to focus on just those objectives. In order to preserve some of the interactive functions, we really do encourage participation, muting, unmuting. We created drag and drop games through PowerPoint to kind of preserve that aspect as well. For collecting the biometric data, this was a concern of ours that we brought up to the food bank. We didn't want to do the program and not have any way of measuring the effect. So the food bank made available blood pressure monitors and waist measuring tapes for each participant. The participants are then able to keep these, which proved to be an incredible incentive and also kind of encourage the sustainability of the program, which is wonderful. We arranged pickup times, designated pickup times where patients came in one by one to pick up the blood pressure monitors. We also collected the biometric data right then and there. And nurse case managers or trained health educators were on hand to teach the participants how to use the blood pressure monitors accurately. The third thing was addressing lower tech literacy. This program usually appeals to our older patient population. They tend to not be as comfortable with some of the technology. May have nieces and nephews or grandkids helping them out. They may not have the best internet connection or access to some personal devices. So we created a session 0. This was by the suggestion of the food bank. This session 0 served, before we even dove into any of the content, it was an opportunity for us to get together with the entire class virtually, iron out any sort of technical issues, really troubleshoot, make sure people understood the muting functions, the camera functions, the chat box, things like that. And that has actually proved to be pretty effective in making sure that when we do start the class, people aren't missing out on any important information. And lastly, reducing food insecurity, which is an objective that of the course in general of the program, and something that we really work for here at our community clinics. As we all know, food insecurity intensified in the wake of COVID-19 and the pandemic. So participants continue to be enrolled in the Food RX program for during the Core Connections cohort that they belong to. All the distribution sites moved to drive-through distributions. So it really was reinforcing and constantly encouraging through lots of follow-up patients to go and redeem the food. Next slide, please. So far, our results, this is very much so still in implementation as of last week, or I guess this week too. We've had 3 completed and 1 current cohort, which have yielded 44 unique participants. 1 cohort, the first one was conducted in Spanish, which is the first time that we presented Core Connections in Spanish, and 3 in English, with participants from 5 different UT physicians clinics, as you can see in the chart, the breakdown there. It's interesting to note that when the program was implemented in person, it was mostly done in the clinics that had health educators. So we only implemented it in 3 clinics, I believe. So it's interesting to note that as we've expanded to this virtual platform, we're able to reach more patients that may have otherwise not been able to attend the class in person. A total of 42 blood pressure monitors have been distributed. We followed up with patients and gotten feedback that they continue to use them and log, which is wonderful. So far, we don't have results from the pre and post surveys from the food bank, but qualitatively, I can share through feedback we've gotten from patients participants who've completed the cohorts. They're really pleased. We were really worried about losing the magic of the support group aspect of Core Connections and the face-to-face interaction and how important that is to adult learning. But I think we've been able to preserve that so far. We do have lots of participation, even amongst all the muting and unmuting. So we're hoping moving forward to expand the program to more clinics, continue ironing out any kinks, and hopefully successfully offering this to more patients. Thank you.
Good afternoon. I'm Annie Mathukuti. Can you all hear me? Hello?
Yes, we can hear you great, Annie.
Oh, okay. I'm Annie Mathukuti. Thank you for having me on. I'm excited to be part of this special momentum. The title of this poster is Virtual Hypertension, High Blood Pressure Symposium for Veterans and Caregivers. And I thank Daisy Thomas and Annie Joseph for their contribution in this poster. And this symposium was made possible by our colleague, Mr. Shaheen Monsef, who assisted with technology, and the presentation by AHA, Dr. Koshi Nesbitt and Dr. Takia Wilson. And blood pressure and medication was presented by the pharmacist, Dr. Sigler, and Dr. Stroud. And becoming sodium savvy, tips and tricks for a low sodium lifestyle was by the nutritionist, Ms. Fruit. Next slide, please. National Center of Health Statistics 2017 estimated 37 million adults in USA, or nearly half of all the adults, have high blood pressure, and it increases the risk for heart disease and stroke, which are the 2 leading causes of death for Americans. In 2018, over 37% of veterans were diagnosed with hypertension, making it most common chronic medical condition. 80% of the patients referred and enrolled in home telehealth program are related to high blood pressure. Home telehealth department staff identified significant knowledge deficit about the self-management of high blood pressure at home among these patients and caregivers, and this led to the idea of organizing a virtual educational symposium where pertinent information could be delivered on a single platform from the comfort of their home to a group of veterans and caregivers. Next slide, please. We will quickly go to the review the objectives. To increase the awareness on prevention, treatment, and control of hypertension among the veterans and caregivers via virtual learning event using the PDSA methodology of veteran healthcare system, which is plan, do, study, and act. The second objective, to provide evidence-based initiative to the veterans and caregivers through virtual resources that aims to address high blood pressure by partnering with interdisciplinary team and American Heart Association. The problem statement in the plan. Home telehealth identified significant knowledge deficit and gap in the perception about the self-management of high blood pressure at home among the veterans and the caregivers at the end of 6 months period of their enrollment. Home telehealth coordinators educate the veterans through phone. There is no option for other learning methods for the veterans and the caregivers to assist them to motivate learning. There is no visual learning taking place in the program. The information provided to the veterans is not appropriate at the 7th grade level. Actions and improvements. Transform the nursing practice using advanced technology, WebEx software, PowerPoints, and videos to improve the patient outcome. We partnered with various leaders and departments for the approval, coordinated with high-skilled and experienced interdisciplinary experts like PharmD and dietitian and American Heart Association MD and Senior Director to share their expertise using the PowerPoints on the management of high blood pressure based on the challenges and problems in their daily life, and videos on how to check blood pressure using home blood pressure monitor for the veterans and caregivers, and all these at the 7th grade level. We contacted the patients and emailed the flyer with the details to the veterans and caregivers and set up reminders 24 hours and 1 hour before the session for the 3 series. We conducted practice session for the veterans and caregivers to check if there is any barriers in connecting. Improvement results. Conduct pre and post polling for each series, develop graphs of the results of the poll, collect feedbacks from the veterans and the caregivers via emails and calls, meet the veterans and caregivers request for the PowerPoints and other visual tools as a keepsake and for future reference. Follow-up action. The home telehealth care coordinators will monitor blood pressure of the veterans who attended the symposium and analyze the data collected for the improvement and sustainability during 3 months period and 6 months period. A follow-up will be done in a week, 3 months and 3 months to identify if the veterans need further educational materials. We'll continue to conduct symposium tentatively twice every year on hypertension and other chronic disease management. Next slide, please. The result. The virtual hypertension symposium was an effective approach of learning event to achieve optimal knowledge to control hypertension among veterans and caregivers. The graph on the poster indicates that the veterans gain knowledge, especially on how to manage hypertension with heart healthy diet by understanding, reading the food labels, choose food wisely, quality nutrition from healthy food sources, differences between salt versus sodium, label language on the food packets and cans, tips and tricks for low sodium lifestyle, etc. Summary of the conclusion. As a result of the symposium, the attendees gain knowledge and understand the topics and able to make lifestyle changes using various visual tools. Home telehealth at North Texas Veterans Healthcare System will continue to assess the knowledge and deliver high quality patient care by finding new ways to improve the veterans' health. Can we go back to the poster, please? Here on the result, you can see the graph. It's not, I cannot see it complete. On the nutrition graph, the veterans gained lots of knowledge because usually when we talk on the phone, they don't have the picture of how to read the labels and how to label languages on the food packets, cans, tips, and the tips and tricks of low sodium lifestyle. So this symposium helped the veterans to gain knowledge. Thank you very much.
Thank you so much to our wonderful presenters in our final category of leveraging technology and clinical engagement as it relates to hypertension. So up again is our poll for voting for your favorite abstract in this particular category. So there again listed are the titles and authors for each abstract. The poll will be up for 15 seconds. So make your vote, cast your vote now. Also, the links to the posters are in the chat box. Thank you so much for providing such great information in this category, and to all of our speakers today. I think everyone should give them a virtual round of applause. So excited. Okay, so again, we just want to take this time to thank all of our presenters for sharing your initiatives to promote hypertension control across the state of Texas. Additional resources are listed here on the screen and also in the chat for your review. Also in the chat is how to join a regional collaborative. And with that in mind, we would love for you to email Heidi McPherson today so she can provide more details how you can be a part of this incredible movement across our state of Texas. I want to again recognize the team of all 4 host organizations, the American Heart Association, Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership that made this virtual series possible. And finally, we invite you to register and join for the remaining session of the 2020 Texas Hypertension Control Summit Series. So next up, December 3rd, the American Heart Association's own National Chief Medical Officer, Dr. Eduardo Sanchez, will be leading our virtual awards ceremony, recognizing those healthcare partners who achieve participant or gold level status in the state for your participation in Target BP. So watch for your emails for details on how to register for the optional photo opportunity with Dr. Sanchez. And remember, we will announce the fan favorite poster from today's event on December 3rd. So with that, everyone, thank you so much for joining in and tuning in to our session. We will see you all next month. Bye.
Thank you.
Thank you.
Bye, everyone. Thank you.
Bye-bye.
Just a small town girl living in a lonely world. She took the midnight train going anywhere. Just a city boy He took the midnight train, 'cause